this topic. So our second panel is representing our second pillar from the strategic plan called Innovation and Influence. And the little funny title is System Transformation, G to D. You go first.
Hi everybody, I'm Dr. Kobe Policy Director at Apple Tree. And wow, those speakers in session 1, just to tell all the speakers in session 2, you have big shoes now. Because we heard a lot about overcoming barriers and not doing Band-Aids, but doing real system change that allowed programs to be sustained. So I think that that is incredibly important. Okay, there's my sidekick. So what do you do? Anyway, reminder to submit your questions. Do them as they come up along the lines. We have that. And there's your QR code again. Yeah. So this slide is just to say.
Just keep going, Deb. I'll catch up. I just wanted to make sure people.
That computer isn't controlling the slide.
That's why I said.
Yeah.
You said you do it.
You have to do yours.
You have to do yours, Deb. She's watching. And she's
I get it. Okay. Now, there, we're all about innovation, not necessarily about technology. Innovation. And you're going to hear some really fabulous people. But Apple Tree takes that innovation so to heart that we have 6 innovation teams that you can see listed here. And there's not really clear designations between them. They all overlap and intertwine, and the different teams meet together. And why does this matter, and what's the urgency? This Health Affairs is a lovely public health journal, highly respected, and they know that research shows it takes 17 years from knowledge to practice. And when we have things, this particular article was about the fact that SDF, we don't want to wait 17 years to move towards minimally invasive dentistry. We'll hear from Steve Barbeau and the folks that even brought that to the United States so that we would have that option. So that's what our innovation teams were about. We're about finding the new and the next that's better for our patients. And you're going to hear about other people doing the new and the next and innovating. So with that, I'll turn it over to Dr. Slasheva to talk about our learning health system. Thank you, Deb. My name is Liba Slasheva. I'm the research director for Apple Tree. I'm going to be describing to you Apple Tree's learning health system. This is a concept that I hope is gaining familiarity, and it's going to be as familiar as the AAA. Everybody knows that, right? Have people heard about the learning health system? All right, well, we'll catch everyone up here. So Dr. Helgeson has adapted that concept that comes from the American research ARC, quality health research, anyway, some federal agency that studies the quality of healthcare. They've developed this concept that's starting to spread into hospital systems, and Apple Tree says, well, why not? We want to be as robust in our operations and innovative improvements as all the rest of the companies. So at the center of our learning health system, of course, is our model of care delivery, community collaborative practice. You won't be surprised that this has shaped the way that our clinical care delivery models have evolved, the populations that we've expanded to serve, and co-locating with hospital systems, launching teledentistry programs as a care delivery system, and expanding to ever more populations that experience unique barriers to care. And we have always done this in partnership with our colleagues across disciplines, in different regions of the state and country, in the way that we've collaborated with folks outside of the healthcare world to advance policy change and workforce advancements. There we go. So the delivery system, we've worked with our partners to fine-tune and tailor to each individual region of the state and specific populations that we serve.
exploring lots of little moving parts here. One really exciting thing that Appletree's been involved with over the years, and we've been able to formalize due to the generous support of the CareQuest Institute, and we have Eric on one of our panels today here, is collaborative research. And, making sure we're evaluating and improving the way we're doing our work, but also representing the populations that are all often not represented well in scientific studies. So making sure that the health system is working for them. And then lastly, clinical and policy innovation, education, systems innovation, workforce innovation, making sure that it's driven by evidence from our context. All right, it's hard to do this, so I'm glad the speakers don't have to do it. And you'll be hearing a few examples of some of the ways that we've innovated over the years. One more time, you'll see the graphic all together here. Hopefully you're a little more familiar with Appletree's learning health system and the concept more generally. And the reason that Appletree has decided that we've always operated as a learning health system, now we have the language to describe it, but the reason that we acknowledge that this is important to continue to build out and operate as a learning health system is because we want to be equity-focused, patient-centered, and make sure that that evidence emerges from our setting, gets incorporated back into our setting for improved care, and to overcome all the isms that our patients experience when we're focused on overcoming those barriers. And you can access the bios for our wonderful and accomplished presenters on this QR code. Please keep those questions coming in as you go. Okay, welcome Dr. Colleen Brickle for the first presentation.
Okay. Well, first of all, thank you for inviting me, Dr. Helgeson and Appletree. I have too many slides, but that's to give you some feedback that you can give me during the lunch and other opportunities to really talk about. Appletree is a part of every one of my slides. So it's really the higher education role that I'm going to talk about today. Okay, there we go. So I love this. This is a puzzle piece that was put together by many, but access to prevention, access to care. We know the two Surgeon General reports that came out, they were seminal, and that really was a jump start for Minnesota and the nation. Really, for Minnesota, it was really to meet disruptive innovation, and the driver was access to care. And we couldn't have done it in higher ed without community partners such as Appletree to really get us going and to ignite us to start doing the right thing with our graduates. So I like to use these. Over the years, there's really big goals. They would change, but in Minnesota, like I said, it was really the advocates in this room and everywhere around the state that really were access. It was all about access. So how are we going to do it? How are we going to expand that workforce to really improve the models we have? How are we going to establish policy at the legislature, rules at the Board of Dentistry, so that all oral health practitioners can move to the top of their license? And the last one, then, if we did the first two, then we could deliver basic health care to everyone, to patients and communities, whatever community needs to you. That's open debate. But I think we know we have new challenges coming, so we've got to remember this again as we move forward and really transform. Minnesota first. Well, I always like to put this 2001, it was called limited authorization, but we weren't the really first with that. It was Mexico and Maine, but our legislation was more robust and we added restorative functions to it for dental assistants and dental hygienists, so I like to say we were first with that. Very important. 2005, the community health coordinator that the ADA had, well, we had our own already here. It was a community health worker. Minnesota State had a curriculum. It passed that curriculum. If you had it, you could bill for Medicaid. So that was very important in the frontline health equity people that really know their populations. This is the big one, I think, for many of us in the room. We were the first state government in the United States to authorize licensure for dental therapists and certification for advanced dental therapists. And I'm going to talk a couple little slides on each one of these really quickly because I'm most proud of all three of these. I love this. This was based on advocacy. So in 2003, Apple Tree worked with Normandale, thank you, and we did a survey of dental hygienists. And then again, we did it later in 2019. But this step ladder just shows you it took persistence. It wasn't just oral health or dental providers, it was oral health advocates. All these steps, each time it got better, we were relentless. It was the passion and commitment of so many people. And this model still is working its way. It still has a ways to go, so people really appreciate it and have value to it. Because it's, sometimes I think if that would have taken off better, maybe dental therapy wouldn't have come so quickly. So here's the two surveys I sort of talked about. The first one was in 2003, and then we did it again in 2019. These were how the first gave us funding. The table, look at the change in 16 years. What was the number one? I mean, dental hygienists are preventive and we care. It's helping to improve access. Then you look at the other column and what aspect heightened awareness. Again, look at all in going down. Number one far outweighed the rest was helping people. But in the middle, it was more about professional development. It was about how we could work to the top of our license more, and that needs attention. Of course, wages and salary are at the bottom, but we can't lose sight of the thing. We need to work on the financial stability if we really want this model to work. So, but I love this because I think this tells everything. Autonomy was lowest in 2003, then moved to 10 years. Another thing, I love this slide. We didn't see the slide in dental therapy, but we did have more green dots. But what this is showing you is this was in 2017. So what happened was the National Governors Association and the National State, doesn't matter, I have it written down here, but they came together, state legislatures. They came to Minnesota, worked with the Department of Health and the Office of Rural Health and Primary Care. Well, we had a group of us, there's a lot of us in this audience, that took the framework and we proved it and had statutes, so we moved forward. So this shows you why to see all the green was really nice. Community health workers, take a look at this later. They are frontline. Look, their growth, if you don't know much about them, you really need to have these workers with a certificate and really know their communities. Of course, I'm just going to say this, we are a classic example in Minnesota of what's collective impact. It really is. It's taking all the things, a goal, working together with organizations, and we made it happen. It wasn't always easy, but it worked. And now today, we have 3 programs. That's a first in the state of Minnesota. And more importantly, there's 165 dental therapists and 120 advanced dental therapists as the NFYs. So what are we going to do for the future? Well, current practice is, I can't read all of them, we've already heard about, but telehealth, teledentistry. We need, it's the best way to reach people and use our staff and technology, the biotherapeutics, artificial intelligence. We could spend an hour on every single one of these. But especially, I want to talk about the very last one. There's something that just came out in Canada, and they now have a biomarker that they can identify in saliva breast cancer. So we have so much happening, we can't lose sight of federal, our government. So what's our call to action? We have a lot to still do, especially with the changes ahead. So I think first of all, we all know, we've talked about this already, the triple and the quadruple, and now the quintuple. But to me, we will get to that better health improvement, but we've got to look at the clinician well-being more than anything. We lost a lot through the pandemic. Can't lose sight they're as important as our patients. The other thing is interprofessional education collaboration, medical dental integration. We can't be siloed. It's working in education, especially community colleges. They've done it in universities. We need to get this done. And we're doing it at Normandale now. And please reach out to me. I'll talk to you more, but I'm very excited about us working together more than we have. And the last one, of course, always policy changes to get rid of the barriers and inequities. But unfortunately, the reality right there, the political determinants of health are really the social drivers, now more than ever. And we need to be aware of that and really make it work. So I just had to put my little Heather up there for a moment, but the first class of pioneers, and many of the other dental therapists in advance, but thank you. And just for a little fun, congratulations. And again, this is so wonderful to be part of this. Thank you.
Well, thank you very much for inviting me. My name is Steve Pardue with Elevate Oral Care, and congratulations to Apple Tree Dental for 40 years. I've personally been in dentistry for about 26 years now, straight out of college with absolutely no knowledge of dentistry. I learned a lot in that time. Most of it, in fact, almost all of it, has been focused in preventive dentistry, so specifically to fluoride, antimicrobials, chlorhexidines, perio treatment, oral malware, those types of things. I was trying to think back to the first time that I actually set foot in an Apple Tree office, and that was probably 23 years ago. I was there to drop off a early caries detection system. It was something we were trying to take from the research world and move it into the clinical practice world, and Apple Tree Dental was generous enough to review it for us and look at us. And that day I learned two things. One, the system that we were trying to get into clinical practice was nowhere near ready for that. And two, Apple Tree Dental was nothing like any of the other dental offices that I've been in. So that's a testament to what you guys have done and put together and continued. So thank you for that. So what I want to do today is kind of give you a view of who we are, what we try to do, and how we bring products to market. So as I said, we focus specifically on prevention. So we want to stop restorations altogether if possible. And we know that's not possible, but we want to reduce the frequency that they need done. And that takes forging some paths, changing some things. And in the 20 plus years I've been in this, it feels sometimes like you're not making a lot of progress, but if you take a minute and look back, we are. For example, fluoride varnishes got to the US in 1995. The first insurance code for fluoride varnishes was until 2006. It's a delay. Silver diamond fluoride hit in 2015, we got a code in 2016. So prevention's coming around. It's slow, it's hard to turn the ship of dentistry, but we're pulling them until they're in the right direction. So when we start to look at how we bring products to market, we start with some questions in mind. And those are normally the obstacles that we'll run into when we start to put them into practice. The ones that are circled in black here are the ones that I imagine Apple Tree Dental sees day in and day out. And the ones that are circled in green are more the ones that we have to focus on how we can get something to the market. I could spend an entire afternoon talking about just the FDA regulations and the on-label and off-label and how you get a product to market through the regulatory claims and process. I would love to do that, but I can't squeeze that in today. But that's where I spend most of my time now. I do product development along with my business partner, Kevin Thomas, and then regulatory pathway clearance. So that's what we specialize in. There we go. So how do we overcome those obstacles? And the answer is we do exactly what we're doing today. We're out in the industry, we're part of it. We're one of the founding members of Canberra. We're at the Orca Caries Conference in Europe every year. We're at the IADR. We take part in these things. Our company is just a team of 64 people, so we're small. But at the same time, we're out in the industry because that's where we meet the people that come up with the new ideas, the chemistries, the technologies. And they may not have the expertise to turn those into products, but we do. So we partner with them. A lot of the products in our portfolio are not things that we dreamed up. They're things that we found with other people in the industry and helped bring them to market. So that's where our expertise comes in. We're part of the standards groups. So the American Dental Association and the ISO standards that put out standards for what fluoride varnishes are, what mouth rinses are, what toothpastes are. We're on the boards. We're part of those groups. And so it helps us do what we need to do. And that's led to numerous firsts here. Some of these were at our previous company, Omni World Pharmaceuticals, if you've been around long enough to remember that company. But a lot of these are with Elevate Oral Care. We've got some new ones that are coming out. One of our recent ones is a chemical caries removal that's self-limiting, so it's inert on living tissue, which is kind of neat. And then some other silver fluoride chemistries. So we've got one that actually supercharges how much fluoride and how much silver you can put into the tooth. So some great things. And then where do we go from here? The million-dollar question. I don't have an answer for that. But our eyes are always open. We're looking for better remineralization technologies, and these things may not be fluoride. There's a lot of peptides and proteins and other chemistries that actually work really well. So we've got a lot of irons in the fire here, so we're working for future things. But happy to be here. I want to say congratulations. We're going to keep providing more tools for your tool belt, and that's all I got.
Intelligence. Undoubtedly, everyone in the room understands the importance of this topic. It will reshape society, and certainly what we're doing in dentistry, and help close some of the gaps that we've been talking about this morning. So glad to be here, Mike and team. Happy 40th anniversary. It's an amazing achievement. The work you guys are doing is fantastic. When the first question was posed this morning about what do you think about Apple Tree Dental, I said two responses: caring and innovation. Let's talk about the innovation that these folks have adopted to help us drive down these care gaps. Artificial intelligence, what is it? Computers making decisions that we could make, that they can make for us quicker and easier perhaps in many cases, right? Taking some of the mundane tasks that we are often burdened with and being able to eliminate them from our plate so that as humans, we can do the soft skill work, the higher level work, the creative work, right? Automation is an amazing thing, and it's going to drive efficiencies and oral health outcomes in the proper direction as we move forward to the future. There are basically 5 different types of artificial intelligence if you think about the type of functionalities you can see on the slide there. In dental, we're using natural language processing and computer vision primarily. Those are the 2 types that we use. Let's talk about the basics. The question often comes up, what are these algorithms all about? What is this software doing, and how is it built? We train these models, these software algorithms, in a very similar fashion to how you might train your child to understand the world around them. It's through repetition of data. We see data over and over, and ultimately the models become sophisticated enough that they can understand the world around them when faced with something they haven't seen before. Like an image on an X-ray as an example. Now, in our use case in dentistry and medicine, these things are controlled. We use a supervised learning process to train the models. Licensed clinicians, like lots of us in the room, train these models, and then ultimately validate the outputs. And that is the basis for what is our FDA clearance process. These are Class 2 medical devices. There's some risk if they're used inappropriately. We need to understand that. So clinicians in the loop are an important part of what will always be this technological development. Okay, the foundational things. We have to teach a model what an X-ray is, or it might well think it's a dog or an apple, that's an example, right? So we have to teach it what an X-ray is, how the X-ray is oriented. Is it a right-wing X-ray or variable X-ray or panoramic? All that has to be baked in before these models can determine, I think I see a cavity on a tooth. I think I see a periodontal bone level that's altered. And tooth numbering. Tooth numbering is another very basic process that has to be trained into the models. And it doesn't just have to be trained into the models, it has to be perfect. Because if an algorithm determined that tooth number 12 was tooth number 21 and ascribed a clinical finding to it, it wouldn't be worth much to us, would it? So at the end of the day, the algorithms are taking in these unseen X-rays, unannotated, that they've never encountered before, running artificial intelligence models on them. We do this in the cloud, and then back down to, say, your workstation is your dental chair, and you see the output that you see on the right-hand side of the screen. And importantly, what we get with the output is color and quantification, or numbers that patients can understand, helping to drive patient understanding of their condition, which leads to increased case acceptance, closing some of the care gap. That's what this is all about. and utilizing technology to do this is overwhelmingly good. So what is Overjet all about, our company? Overjet really is, our goal and our mission is patient-centric dental care being facilitated with artificial intelligence. We aim to be the leader in dental artificial intelligence and ultimately to provide a solution that will help run any form of dental practice or organization in a more efficient and patient-centric manner. So we'll talk about how we do that. Some of the things that we're involved with are clinical care AI, right? So what are we using at the dental chair level? Dental AI Assist, you just saw an example of that on the x-rays. We're using computer vision to actually make an assisted diagnosis of a dental x-ray, right? Helps a clinician perform a diagnosis more efficiently and ultimately more precisely. AI native imaging, we have an imaging software that has artificial intelligence baked into it. It's sensor agnostic. A clinic could take radiographs with their own sensors. We would run artificial intelligence on the outputs, and then you'd have right at the dental chair the ability to not only take your images in cloud-based software, but also to have artificial intelligence reads come out with it. We're also heavily involved with data. Of course, you guys understand that data forms the pillar of artificial intelligence. That's what holds it up. And so we deliver things like high-level analytics for organizations like Appletree as an example to help leaders in the organization understand things and metrics about their organization, the patients that they're serving, and ultimately their communities as well. But we also work on the payer side, and this is really important because the payers are where the money's coming from, right? So we have products around insurance verification, RCM, revenue cycle management, including a very innovative product that you guys will be hearing about soon, where we're tying payers and providers together to make the ultimate claim situation much, much more efficient in real time, actually. The payers use artificial intelligence to increase the speed of claim payments. That's been occurring since about 2018, and good things are happening there. We have portals for the payers where they can manage their pools of providers. Even recruiting, we're helping the payers recruit clinicians for their groups. And then we're in the dental schools. Artificial intelligence is in about 20% of our United States dental schools right now, helping the next generation of clinicians up-level around this technology, which will transform society entirely. Let's talk about Appletree and Overjet quickly, because I think Appletree is a very, very unique organization. We all recognize that. But from our perspective, being technical people, we don't see this very often. And congratulations, Mike and team, for what you're doing here. Some of the things that are being done here at Appletree involve research, as you saw. And some of these initiatives are super, super important. And oftentimes, a dental organization almost doesn't have the time for research, right? And that's a sad thing. But Mike and team are using artificial intelligence to help with these research efforts. How do you implement AI across the dental organization, as an example? Evaluation of patient perspectives on AI. What do the patients feel? What do the clinicians feel like when they use artificial intelligence? Phenotyping and periodontal disease. Clinical applications of research studies being facilitated with artificial intelligence. So in closing, thank you all for inviting me, Mike. Congratulations. You guys are doing wonderful things up here. And I'm really glad to be back in the Midwest again from the South. Thank you all so much.
Good morning, everybody. My name is Eric Traney. I'm the Senior Director of Analytics and Data Insights at CareQuest Institute for Oral Health. It was a perfect transition from Greg, given that three of those screenshots you showed were research that we collaborated on with Appletree, focused on the Overjet evaluation, so almost like planned it that way. My talk's going to take us through a little bit of a higher level, focusing on the use of real-world data to to make change to improve oral health. Before I get into that, I wanted to talk real quickly about what CareQuest Institute is, if you're not aware. So we're a national nonprofit with a mission to improve the oral health of all by making it more accessible, equitable, and integrated. We do that, focus on some core areas of activation, including analytics, data insights, or a research area that I have been my honor to be a part of over the last decade or so. We also have philanthropy. I see 4 of our grantees maybe in the audience right now, including Appletree and Betsy and a series of other folks as well. Education, innovation, etc. Within my area, analytics and data insights, it's been my privilege to develop real-world data assets that we use to conduct research and analytics. And so we have claims data of over 100 million Americans. We've got more than 1 million Americans EHR data. This is a little old now. I think we're up to like 2.5 million. And we collect consumer and provider data. Again, I just did another provider survey, so I think we're up to 4,000 dentists who've given us some insights into the way in which they do work. We use that data, like I said, for research, but we also try and short-circuit that 17 years that Devin's talked about by really making that data real world, making it impactful, and allowing others to use it in a way to advocate for change is key things that we focus on overall within our work. So what I'm going to focus on for the rest of the talk today is kind of 3 lessons that we have learned when you're using research, information, and data to try and advocate for change. Data matters because it's a source of truth. We can make quality improvement decisions. Some of the talks a little bit ago were focused on that, helping inform the decisions, measure impact, and then build trust with your stakeholders. If you're transparent and reliable with your data, if you're honest about what you see, both good and bad, you build a relationship built on trust, honesty, and truth with your stakeholders, with the people that you're talking to. But those 3 lessons that we have learned is that data is not just a research tool, it's not just a business tool. Data allows us to tell a story. So we have to frame a story in a way that is impactful and meaningful for the audience that we're talking to. Sometimes that audience is researchers. I publish 15 research articles a year in peer-reviewed journals. We use a very different language and a very different way of speaking to that audience than we do when we're writing for something that we think is going to land in USA Today. We were on the front page there twice last year. Or we talked about it in front of the Senate. So you have to think about the way what you're saying and how that tells a story. Our story often talks about that oral health is in crisis in America. More than 40% of adults have untreated tooth decay. There's more than $3 billion spent in ED visits for dental. 30% of Americans report that the state of their mouth and gums affects their ability to get a job and career. We know that untreated oral health needs are common and costly. Dental care is the highest level of cost barriers of all other health services in the United States. More than half of adults report that they have some untreated dental condition in our survey work. And they don't get it treated. Partially, it's not severe enough. I would argue that lack of severity really talks about access to preventive care, really tells us about what people are willing to adapt to when they can't afford it or don't have robust access to care. But the majority of people who don't see a dentist or report that they don't is because they can't afford it. That lack of access to oral health care is expensive, not just for the individual who has to go pay for it, but for our communities, for our economy. More than 243 million work or school hours are lost annually. Again, this is based on some of our survey work, leading to more than $45 billion in lost revenue annually to our economy. That's a lot of money that we have here. And we know that oral health care is crucial for whole person health. But it took me, 2 minutes? And I told the whole story there. That is years of work that we've had and that we pulled together. But we're using it to tell a short story to try and convince folks that we need to take seriously this lack of access to oral health care. It's not just about that storytelling, though. The storytelling doesn't matter if it's not personal or impactful for people. So what we know is that all data is personal and local. We're working to make that data local. We have, we're producing evidence that could reach your local level. Here's a state fact dashboard that we released earlier this year that tells you information on, look at information on Minnesota, the percentage of the adults without dental insurance, those who have to drive more than an hour to see a dentist, those who can't afford dental care. Later on this year and early into next year, we'll be releasing information on Medicaid access to care and costs that go all the way down to the zip code, congressional district, or county level to help get you guys some of that core information that you need. Beyond just the data, though, those stories have to be personal, and we work with our marketing, our PR teams to make some of that data personal. Here we talk about, you see some information that we've done focused on with teledentistry. I think Betsy, we cite Betsy's work at Access Care in this particular article. Or some consumer or patient-facing information that we released with Lunder Deneen, a consumer patient advocate organization in Maine. And then the third element that we have to engage in is demonstrate alternatives. We need to know that there's a problem. We need to make that problem real for people, and then we need to say what would happen if we were to fix that problem. I know these are complicated charts here, but generally what we're showing, people who have 5 years of preventive care cost less than those who don't. There's an alternative. If we have access to preventive care, we know that it costs less. We know that Medicaid adults who have access to periodontal services, who have diabetes, cost less than diabetics who don't. We're demonstrating the alternatives. We're showing you what can happen if you make that set of change. We're showing you what can happen if you innovate in oral health care. Appletree's a leader of that. We just heard from Overjet, who's also a leader in that. We also know that data needs to be better. We're working to make that happen. We are set to release a large-scale data platform we're calling our data exchange efforts to work with payers and providers to share their data, get others' data, and report out and develop some of these stories, alternatives, these alternatives to care and others. So if you want to hear more from me, there's my email, grab me at lunch or other things. Stay engaged with us, go to our website, sign up for newsletters, and we're always releasing new information. Thank you very much.
Good morning, everyone. It's a pleasure to be here. Thank you to Appletree and the leadership for the invitation to celebrate your 40th anniversary with you all today, and talk a little bit about some of the collaborations that we've been involved with. So I'm Ryan Never. I'm a cardiovascular disease epidemiologist at the Mayo Clinic. Diane's still in the room. I grew up 12 miles south of Fergus Falls, so I appreciated hearing about the local efforts going on in that area. I'm going to talk a bit about an area of research that has been central to the research that I've done for over 20 years, which deals with the relationship between oral health and periodontitis more specifically, and cardiometabolic health, with the oral microbiome at the center of that. And we have some exciting new partnerships between Mayo Clinic and Appletree that are starting to emerge, and we're hoping to actually get into the clinic and start with research within the next year if federal funding becomes available. We're waiting to hear on that. So it comes as no surprise to people in this room that there's a well-known relationship between oral health and systemic health, and particularly diabetes. We know that people with diabetes are at a much increased risk for the development of poor oral health outcomes, periodontitis, periodontal disease, and other outcomes. And there's an emerging body of evidence that I've been part of for over a decade, looking specifically at the oral microbiome and its contribution potentially to the early development of diabetes and the lack of proper diabetes control once diabetes develops. There are some major challenges here, because when we think about the oral microbiome as a contributor to systemic disease, we are not to a point where we can say that is definitively causal, and that prevents us from taking clinical action and making public health policy. Some major challenges to determining causality from a scientific perspective relate to things like bidirectionality. These things feed back on one another, and it's difficult to figure out the chicken and the egg story. Second, there's incredible mechanistic complexity. I'm not going to go through every aspect of this slide, but it's a piece of a very complex puzzle that potentially links the microbiome to systemic cardiometabolic disease through a number of different biological mechanisms. And then there's long latency. So diabetes can probably affect oral health in a fairly short amount of time, but many of the hypotheses linking oral microbiome to systemic outcomes could take a life course, or decades at least. To tease that out, we need very specific designs that are complementary to one another. So I've been focusing very much on how we can improve causal inference, but also have real-world impact and clinical and public health policy making impact in the work that we do. One area I've become very interested in is implementing more clinical trials in this space, and specifically not the typical clinical trials that one might think of, but pragmatic trials that collaborate with clinicians in ongoing real-world practice in a way that takes the research from the community and the clinical practice and then feeds back to that clinical practice with the findings that we have. These approaches have a real opportunity to enhance causal inference because they reduce confounding bias to a large degree. They enhance validity because we're taking data from real-world populations. And a really important piece of this is that they increase efficiency without sacrificing validity, which is extremely important because, as been mentioned several times here this morning already, we are definitely living in a resource-constrained world, and that's only going to get worse, and the research community is certainly feeling that. So we have to find better ways to get good data delivered to clinical practice at lower costs. So to do this, we've been in partnership now. The Mayo Clinic has been working with Appletree Dental for at least 7 years, and I've been collaborating for the last 2-ish, particularly with Lubav and Michael and Deborah and many others, to develop a pragmatic clinical trial in the context of a partnership between Mayo Clinic and the Rochester Epidemiology Project, which we'll say a bit more about in a few minutes. The core goal here is we want to run a trial where we will offer people to free comprehensive periodontal care if they have evidence of both periodontitis and pre-diabetes. The real innovation here, there are a couple, but the main innovation is that we're talking about treating people for their periodontitis in part because they have pre-diabetes, not overt type 2 or even type 1 diabetes mellitus. And this is an innovation because these are individuals, we believe, who have already developed clinically meaningful phenotypes. They have actual disease, that we know they're at high risk for future development of diabetes and worsening and deterioration of their oral health. So why wait until they get to stage 3 or 4 periodontitis and overt type 2 diabetes before we take some action that can have both local and systemic benefits? We're doing this through a partnership, and this is the pragmatic piece between Appletree and the Rochester Epidemiology Project. So the Rochester Epidemiology Project is effectively a massive cohort study in the 27 counties around Rochester and Holston County. And most of the folks living in those areas are receiving care directly through the Mayo Clinic health system. So we have this opportunity to embed research based on ongoing data collection through the EHRs in large communities throughout the life course. And we're very fortunate that Appletree Dental has some remarkable electronic dental records for at least 50,000 patients that overlap with the rep, and that allows us to efficiently enroll people from their clinics and watch what's happening in both the medical and dental records following various treatment approaches. So I'll just conclude by giving a little bit of detail about what this trial will look like. We believe at the moment that we have at least 2,000, if not 9,000 to 15,000 patients who, during the course of a 5-year study, will present to us with evidence of prediabetes and some stage of periodontitis. From that large sample that we can generate electronically by reviewing EHRs quite efficiently, we're going to invite roughly 175 patients to the offer of receiving comprehensive periodontal care, which will go beyond what the current standard of care is for these types of therapies. But the key issue here is that it would be free, and that's a major barrier to people who want comprehensive periodontal care, is that it's expensive, and even if Medicaid covers certain forms of these therapies, it's often denied, and that's a clinical reality that I've learned through the collaboration with AppleTree, that many of the patients who should get the care never actually receive it because the insurance is denied due to usually a lot of bureaucratic barriers. So we're going to cut through that, offer them coverage for the care, and hope that they have higher uptake of periodontitis care, and they'll be receiving more advanced therapies as well. And a really efficient piece of this is we can do that in about 175 patients while enrolling close to 15,000 overall, because we can use the background EHR to monitor A1C trajectories and their oral health care. So I'm very excited about that opportunity, and we hope to start soon. And I just want to conclude by saying congratulations to AppleTree Dental on their 40th anniversary, and thanks again for being here. I look forward to the discussion. Thank you.
Good morning. I'm impressed with the timeliness of this event. I was supposed to come up at 10:30. It's 10:31. I'll excuse that 1 minute, but pretty impressive. I start like most speakers have and just thank AppleTree for the opportunity to be here today and the partnership that you guys provide. Also, just really want to say thanks to all the speakers today. It's been a real pleasure to hear the innovation and creativity and history of the dental program and oral health in Minnesota. I haven't had the privilege to be involved in it as long as many of you have, so it's really great to hear some of that history that I wasn't familiar with. Also, in a small effort to give Mike a small gift and AppleTree a small gift to say, he mentioned that the Critical Access Dental Program is something that they have a lot of pride in, so I did look up while I was in the back there, and our September list shows that there are currently 271 clinics that are critical access dental clinics. For those of you less familiar with the intricacies of Medicaid payment methodology, which as many could do, I could probably do a speech just on that. That's at the clinic level, right? And so that doesn't account for the fact that clinics like AppleTree and many of the ones here have numerous providers within those clinics, right? So that's just at the clinic level. So that's really a large representation of dental in Minnesota. I think it says up there, my name is Giogo with the Department of Human Services. We really have the privilege of running the Medicaid program as well as the Minnesota Care program, serving more than 1.2 million people throughout the state. If you don't always remember how many people are in Minnesota, that's about 1 in every 5 Minnesotans is served by that program. And was mentioned a couple times here, you know, individuals on Medicaid and Minnesota Care are all over the state. There are neighbors, there are friends. And if you break the state down into regions, about 20% of every region is serving individuals in the Medicaid program. And so a program that's really statewide that you guys are all partnering with as well. Unfortunately, and many of you guys know this and known this longer than I have, we've had decade-long problems with oral health in Minnesota, specifically for the public program participants, which is really where I focus my efforts. And we hover around 40% of members in the program receiving dental services. And that, again, for those of you guys not as involved in the intricacies of Medicaid policy, the way we measure that is actually for people that are on the program for quite a few months, so 11 months. So that means that you could be on the program for 3 months. We're not even counting you in that measure. And so we obviously, you know, I don't live my life based on when my health insurance is active or inactive. And so it matters to people when they're getting health insurance. And so that's something that's critical for us to think about. And oral health and dental is one of the things that we get most calls about. People can't find dentists, can't find transportation to dentists, can't find a provider that's taking Medicaid. And so it's a big issue that a lot of us and many of you in this room have been partnering with the department on, and we really appreciate that. I wanted to build on how Mike opened the conversation by saying that despite the fact, and many of you have talked about this, despite the fact we continue to struggle, there's been lots of improvements in this space over the years. I've only had the privilege to really engage in this policy conversation for about 10 years, but even in that time, in partnership with many of you and the state legislature, have been numerous things that have happened. And so some of those being our Dental Services Advisory Committee, which is a statutory mandated group that many folks here have either served on or currently serve on, or many of your colleagues have. we're really working together to talk about how we design the Medicaid and Minnesota Care programs in Minnesota to serve the needs of the people that you guys work with on a day-to-day basis. And in 2021, as many of you know, we all partnered together on a significant investment in dental, around $60 million in a biennium, which is a considerable investment when you look at the number of programs that the state is attempting to run and the amount of money that we're trying to spread across numerous programs. We've had successes in expanding earlier on periodontal disease for members in the program. That was a huge barrier that was communicated from this community. That's something that we weren't able to provide for members. And then most recently, something I think a lot of us have a lot of pride in 2024, we were finally able to reinstate the comprehensive adult dental benefit that had been cut back in 2008 due to budget cuts. And so I know that that's something that's been really important for people to make sure that they get the care that they need, and helps some of the uncompensated care that you all are providing when people would present in the clinic but couldn't get the services that they need. Of course, we haven't fully solved this problem, and we all know that, but we all have additional work to do, and we have some partnerships on the horizon. Just last year, the legislature once again passed some directives asking us to partner once again in a model that we've used and successfully have used with our Dental Service Advisory Committee and some additional friends and colleagues involved, to really look at updating the payment methodology, which we've discussed before and have some general consensus on, looking at how we improve care coordination for the population within the programs, and then also looking at how we improve our performance benchmarks to ensure that we're making sure that members are getting the right services that they need. And so, as I mentioned, lots of hurdles, and you guys have really laid the ground and the foundation for a lot of this work, and we look forward to partnering with you all as we continue that. We'll have some reports due in January based on our partnership, and we look forward to continuing that with you all. Thanks again.
There we go. So speaking up is never anything that someone's told me to do, but I want to make sure So hi everyone, I'm Nancy Frank Wilson. I'm the Executive Director of the Minnesota Oral Health Coalition. And when I thought about being here and sitting in the room, I started making a list of all the people that helped start the coalition, who have served on our board, and I thought, oh, I can't do it. But most of you, or a lot of you in this room, are the reason that we're here. So, the Minnesota Oral Health Coalition, our mission is to strengthen Minnesota's oral health community through partnerships, resources, and outreach. And what I like to say is, we're here for you. We're here for the people that take care of people, that educate people. The coalition's open to anyone, but we really try to make sure that we connect with people that are helping other people. I get a lot of phone calls from the public, and it's just a great honor to say, oh, I know someone that can help you, and connect them with them. We are funded by the Delta Dental Minnesota Foundation, and they definitely do make it possible for us to have a coalition in Minnesota. Brief history about our coalition, and again, Dr. Helgeson, Deb Jacoby, Dr. Brickle, Claire Larkin. There's a lot of us in this room. You guys were there getting it started. About 2008, 2009, the Minnesota Department of Health Oral Health Program had been receiving a CDC grant. I don't know if everyone knows this, but most states' dental directors are not state funded. So when I speak to groups, I always say, can you imagine if our medical director wasn't state funded? No, we'd go, what? They have to write grants? Yes, they do. So the Centers for Disease Control and Prevention gives out 25 grants a year to fund state dental directors through departments of health like ours. And in this 2008, 2009, they started saying to states, look, we love funding you. We think it's great, but we're going to change the requirement and say that you now have to have a statewide independent 501c3 oral health coalition in order to get our funding. So a lot of really amazing people met and got together, and Delta Dental Minnesota Foundation put the money together and said, let's start a coalition. And now, 10 years later, we still have our coalition. So it's a big deal. It makes me a little bit verklempt. In talking about our values, we did a strategic plan about 1.5 years ago, and these are our values. Basically, we want to be a good partner and good people, and when we're trusted with resources, that we take good care of them. This is our strategic plan. Anyone knows that I can really talk, so if you want to know more, just give me a call. I'd love to share this with you. I do want to put a plug in for our American Network of Oral Health Coalitions, and this is really important. And Ms. White, if you're not friends with Crystal in your state, okay, good. You know your state oral health coalition person. ANOC is a National Association of Oral Health Coalitions. So all of us got together. I'm currently the chair. All of us got together and said, look, we need a larger association. And what's really great about ANOC is, I would say, they're my people. So when you contact me and I can't help you, I go, I think someone at ANOC can help me, because we got people all over the country. And they're especially important. Our ANOC is really, really important now that we no longer have an oral health program at CDC, and that our dental director at HRSA was let go. So we see ANOC as having even a greater role to play. Please join us. Please join the coalition. We'd love to have you. And a very, very special happy anniversary. You guys are so special, and I can't imagine the coalition without you, so thank you.
One of the last people that stands between you and lunch, so no. There are more people standing between me and lunch. That sounds good. I'm delighted to stand here and share in the joy of celebrating Appletree's 40th anniversary. My journey with Appletree began actually in 2017. At the time, I used to work for 3M. Eventually, I was the head of advocacy for 3M, but at the time, I was brought into a group of advisors that were called upon to guide 3M's oral health business unit. It's about $1 billion business unit. Was eventually spun off as Solventum, which you see on top of that screen, all of 3M Healthcare. But there were folks from all over the world, and Dr. Helgeson was sitting on the front row, pen in hand, ready to write things down. I remember that very clearly. And we discussed how to change the system. My expertise as an advocate is how you change the frameworks of the system. So I use this graphics because it shows a lot of boundaries. You have to work within regulations, you submit codes, you get reimbursements. There's all this infrastructure that you're trying to live within and trying to make sure you operate within effectively. My job is to change the dimensions of these boxes. You live within it, my job is to expand it to something different. That's the goal of advocacy. Now I'm gonna do 3 vignettes as part of my presentation. The first one is actually, it was referred to by Diogo also, is the advocacy we did to prove to the state legislature that having oral health and support for oral health for people that are under the safety net is something essential to do. Those elements were actually really important from a practical perspective because it enabled us to tell a story different than just dollars and cents. It was impact. Most advocacy is successful if you're able to amplify one of 5 different types of public value. You have to show that the government is running more effectively or efficiently, social value, economic value, innovation, or in some cases, sustainability, etc. And the more of those manifestations you can package in a story, the better the outcome would be. Of course, Appletree has a large reservoir of these stories that we can draw upon. For an advocate, it's a field day to work with Appletree on that. The second step to this was after the success of this, and with my partner Deb Jacoby here and Mike, we began, and with Dr. Sheila Riggs of University of Minnesota, we tried to set out and actually create a coalition within Minnesota that only speaks for safety net providers. And so this is a different way of being able to amplify your voice, pool your resources together, and be able to be effective as you go forward. Now, when you develop a C3 organization that way, your capacity to give and advise increases. It's no longer a company, whether private or nonprofit, that is advising. It's a cross-section of society that's speaking with one voice, and associations have a power to influence that way. But I would say ultimately, the last slide I have here is last year at the National Academy meeting, where Mike, Scott, and a number of us were present, an idea was formed with CMS participating, HRSA participating, etc. By the way, don't give up hope about HRSA funding, because though the president's budget has zero money in it, both the House and the Senate that are now debating Health and Human Services money has more than the $20 million that was there to begin with in their budget. So we'll see what the eventual outcome is. But the goal is to make sure there is a national organization at a high level that covers all dental organizations that try to represent various cross-sections of folks in this country. ADA, Oral Health Coalitions, and many others that do incredible work may require a more overarching activity. And it was really directly a consequence of this meeting at the National Academy. And if Mike had not invited me to that meeting, I would not have been helping him in trying to organize this. So they were formed as a 501c3 on March 20th, which if you don't know, you should mark it on your calendar. It's the World Day for Oral Health every single year by the World Health Organization. So that was the founding day. And today, they're in the formation process and getting the funding that they need to be able to stand up. But their main goal for year one, full year one of operation, is to create a national oral health plan for the United States, which we don't have one. We have suggestions from Surgeon General and other groups, but we really don't have a national oral health plan. None of these things would have been possible if I didn't have the good fortune of meeting Mike in 2017 at that meeting. And it began a cascade of events. But one of the themes I hear in everyone that has spoken here is Appletree brings people together and gives them a platform to be able to create transformation. And so my journey was no different. So congratulations on the 40th, and I look forward to working with you even more intensely on these issues.
Thank you to all our presenters. We're going to move into some Q&A time. The first question is for Colleen. What was the most difficult part about creating, developing the legislation for dental therapy and getting it passed? And what was the most rewarding part?
Can you hear me? Okay. Most challenging was also the most rewarding. I think it was getting everybody together and having a common voice. I have to tell you that collective impact model was challenging, but think about it, we did that in 2 years. But it was the years before and now the years preceding that are still challenging, but they're better. But I just, that was a great question, thank you. But it was probably the happiest time I was during that time. So, but it really took all of us in this room that were part of it. It was a great group effort, so thank you.
Next question is for Steve. Maybe you'd like to comment. What are your thoughts on hydroxyapatite remineralization, D2991 dental coating, and products like Vivardis? Is Elevate coming out with something like that?
So hydroxyapatite technologies are a step in the right direction. So far, none of them have proven as effective as fluoride. So simple fluorides outperform in clinical trials. As you so far. Having said that, though, I still believe hydroxyapatites and peptides and protein chains that attract minerals into the tooth are very important and they're promising. So we just haven't gotten to the right one that's going to be as effective as we want it to be yet. So yes, we're looking at this. No, we haven't found the exact one we want yet, but we've got several things in works.
Thank you. We have a few more minutes, so please submit your questions. I might actually put one of our clinicians or other team members on the spot here. There was a question about, is Appletree implementing hydroxyapatite regeneration into its systems, and what does that look like in the office?
Yes, I think we've been using Curadoc for about a year and a half now. We started with some pilot providers similar to how we brought up on SDF. And then our clinical innovations team working with our optimal intervention program began educating our other clinicians for use of the product as well.
Thank you. The next question is for Dr. Barfield. Which wedding anniversary are you celebrating today? And how does your wife feel about you being here celebrating our 40th?
There's something in life called priorities. This is a special day for Appletree, but this is a very important day for me as well. So I did text my wife this morning. And I'm off the hook. This is the 4th for me. It's a fairly recent one. Thank you all.
Next question for Dr. Dummer. What are the exclusion criteria for your study?
Yeah, great question. The exclusion criteria are fairly minimal, actually. We're trying to be extremely inclusive to make it generalizable and more relevant to broad-scale clinical practice. So, of course, you have to have, there's a minimum number of teeth that you would have to have to be eligible for this particular trial. And if you're free to periodontitis and you have either diabetes or you're not in the pre-diabetes range, you would be excluded. But that's really the primary exclusion criteria for this particular trial.
Thank you. Next question is for Diogo. Deb's going to get her steps in. And the question is, can you share what MDH is doing to preserve Medicaid?
Yes, so the Department of Human Services certainly still doing a lot of the thinking about House resolution with all the changes in Medicaid. Many of those changes probably require additional legislative action in Minnesota, so there are some pieces. But lots of conversations, I can't now have the answers to those today, but lots of conversations going on around we lose funding from providers due to the bill, we lose eligibility for members due to changes at the federal level, what kinds of things in Minnesota are at around. So those are active conversations I'd like to show up during the 2026 budget session.
Thank you. The next question is for John Porter.
Did you notice how when Diogo spoke, there was that I think you would interpret it as like the higher the IQ, the more the spam.
So the question for Dr. Porter is, we know that appropriate oral health care costs less. Employers and legislators don't want to pay more. What do we do?
I would frame usually any request from the legislature in terms of economic and public value impact. To me, one of the things we have to get away from is a partisan view of spending. And so when you reframe the ask as what has the greatest public value, I think you get away from the blue and red sort of binary choices that quite often most legislatures tend to make. Our capacity to advise our legislature natural consequences, yet you have to increase their capacity to understand. And there are at least a dozen classic ways that you can work with the legislature to increase that capacity. Those classic techniques become part of your advocacy playbook and the tactical and operational details that you have to implement to be able to do that. So while I think as a general statement that notion is correct, our goal is to create systemic change. So you need to have a plan for systemic change. And I think there is a way to do that in a meaningful way, especially if you can prove with data, like folks like CareQuest and others are able to share, you can create I think a narrative that changes the dynamics of the legislature.
Dr. Tremby, the next one's for you. Can you please elaborate on what you mentioned, that you will have Medicaid breakdown at county level for each state?
Yeah, of course. So we are producing information on, we're producing a Medicaid policy dashboard, for lack of a better term, that indicates spending, fee schedules for those on fee-for-service schedules, Medicaid population, as well as some other information that will be able to be drilled down, all to zip code level, if the zip code is large enough, congressional district or county. I'm happy to kind of give more information or a preview, but will be targets to release in end of 25, early 26. A more robust set of that information will continue to improve on that information being released over time as well. So we've got some that set up to improve. We know that when I talk about all data is local, the more local we can create those kind of data resources, the more useful they are for all of you on the ground doing that. Some of those but what we're approaching. Lots of missing information. We'd love to know how many providers accept Medicaid, but we know it's a really complicated question to answer across all states and locations, for example. So continuing to develop those data resources, but we will release that preliminary information down to that zip code level early 26.
So the last question is for Colleen in regards to why hygienists were chosen as the pathway for dental therapy and not dental assistants.
Okay, good questions. First of all, to rewarding, I forgot to mention, it's all the graduates that are out there, like Heather, and all of them are doing exactly what we wanted. The law does not say it has to be a dental hygienist, so I think that's really important for you to know.
Does he have number three?
The law just says baccalaureate degree or advanced. The reason myself being a dental hygienist and the support of the American Dental Hygienists Association at the time, it was a pathway that we could only work on one. The university did have two pathways, they now are one, but it isn't in the law, so it means in the future there can be other programs started that could be the dental assistants. So just wanted to give that clarification. Thanks.